Our last discussion for this week's content is the discussion of complex polygenic disorders in childhood. There are two disorders we'll discuss. We'll talk about type 1 diabetes, also known as juvenile diabetes, and we'll also talk a little bit about asthma. These are disorders that have a genetic predisposition but need to be combined with environmental triggers or other genes to activate the pathophysiology. So in a complex disorder, you may have multiple genes involved, and you might need an environmental trigger for the expression of that genotype. And in this case, that genetic factor does not guarantee the person will get the disorder. It's not like muscular dystrophy, where if you have the altered gene, you will not make dystrophin and therefore will get the disorder. It just indicates that there is an increased likelihood. But there are environmental trigger or multiple triggers that interact with that susceptibility to promote expression of the disorder. And there are many we could discuss, but the ones we will discuss are type 1 diabetes and asthma. So type 1 diabetes has an autoimmune component. It's a metabolic endocrine disorder. What happens is that the beta cells of the pancreas are destroyed and can no longer produce insulin. Without insulin, blood sugar cannot move, or glucose cannot move from the blood into the cell. And so we get high levels of blood glucose, but the cells, in fact, are starving. Predisposition is inherited for this disorder. It does tend to run in families. However, having that genotype does not guarantee that it will be transmitted. So there needs to be additional environmental input. It is always triggered by an overreaction in the immune system to a virus. So there are a few viruses that are involved. So the incidence of autoimmune disorders is higher in some families, and sometimes you see different patterns develop. Doesn't follow a pattern for single gene inheritance. It's usually a few genes that are implicated. Type 1 diabetes usually develops in childhood when children are vulnerable to those viruses. So we'll talk about that. Genetic contributions are HLA genes, and these are implicated in immune response. So the HLA genes in type 1 diabetes, when they're activated, tend to attack specific tissues of the pancreas, right, where the beta cells are. So there are a couple of different tissue types, the HLA-DR and the HLA-DQ. I don't need you to memorize those. But if you have those tissue types, if you have that genotype, it doubles your risk. The overall risk is still low. You need that exposure to a virus. It's important to know that this is not like type 2 diabetes. Your interventions are not going to be the same. Yes, exercise and healthy diet are important for everybody, but this disease is not caused by a genetic predisposition and an unhealthy lifestyle. It's usually a viral infection such as mumps, rubella, Coxsackie virus, and that triggers this overreaction of the immune system, and these particular HLA antigens will go after those very specific beta cells in the pancreas. And you have to have sort of a couple of genes, one that makes excess HLA proteins and one that weakens that tissue type, and then you need the viral trigger. So the family risk, it's not as straightforward. Signs and symptoms, you should know these. This is review from many other courses you've taken in this program. When you have type 1 diabetes mellitus, there is no insulin being produced. So you end up with high blood glucose levels. And then you get your polys, excessive thirst and fluid intake, that's your polydipsia, excessive urine output, that's your polyuria. The body's trying to rid itself of the excess glucose through the kidneys. Excess hunger and increased food intake, and that's polyphagia. That's because the cells themselves are starving. Extreme fatigue, and then weight loss. Because the body starts to break down, the brain needs glucose to survive. And if it can't get glucose through the foods that you eat, it will break down ketones. And so, this process breaks fat down rapidly and allows ketones to build up in the blood. So sometimes diagnosis happens because the child is brought in DKA. They may have been losing weight for a while. They may have been drinking a lot of fluid, eating a lot of food, but sometimes that looks like a growth spurt. And the same thing with fatigue. Weight loss will a lot of times bring a child into the pediatrician, but sometimes they don't come in until they're in DKA and very, very sick. Long-term complications, again, this should be a review. High levels of glucose in the blood are toxic to nephrons, which do not regenerate, so nephropathy. Neurons also don't regenerate, so neuropathy, you can get both peripheral and visceral, so the organs like gastroparesis is when the stomach, the nerves don't work and you don't get gastric emptying. Retinopathy, the cells of the retina are nervous tissue, they do not regenerate. So as they get exposed to these high levels of glucose, they can be damaged and die, and you get retinopathy over time. Cardiac complications, the high levels of glucose are also associated with high levels of lipids, so you can see coronary artery disease, hypertension, and MI in people who have lived with type 1 diabetes for a long time, poor wound healing, and increased risk for infection. You know all of this stuff. Amputations of lower extremities as we get neuropathy and poor wound healing, and they're susceptible to things like gangrene, gastroparesis, and many, many other complications of type 1 diabetes mellitus. So it's important to manage it correctly. So type 1 diabetes mellitus, the cornerstone of treatment is insulin. We don't necessarily restrict children from their diets. We just teach them to cover it. So the best systems for controlling blood glucose are to have like a continuous glucose monitoring system, a CGMS. It sort of goes under the subcutaneous tissue and constantly reads those blood sugars and alerts the person when they're getting too high or too low. And then an insulin pump that automatically responds. It's sort of like an artificial pancreas system. Children are taught to count their carbs and adjust their dose of insulin, so they'll program that pump. We don't necessarily tell them not to eat certain foods. I mean, I think there's a lot of food police out there. They hear the word diabetes and they see somebody eating some sugar. But in type 1 diabetes, it's not the sugar that's the problem. It's the lack of insulin to cover it. And then there's going to be a team of specialists, endocrinologists, cardiology, ophthalmology, podiatry, nutrition, diabetes educator. And you probably have to get some sort of family support and emotional support for this child, because children hate being different. And they're subject to, lots of different treatments and seeing lots of different providers. So support through children's hospitals, larger children's hospitals frequently have the resources to help people, and the American Diabetes Association. And next we're going to talk about asthma. You know what asthma is. It's a chronic inflammatory disease of the airways, characterized by those intermittent periods, which we call exacerbations of reversible airflow obstruction. Those of you who are seniors and have participated in the school nurse simulation are very familiar with the pathophysiology of asthma. We call those intermittent episodes asthma attacks or exacerbations, and they result from three actions. Number one, the constriction of the smooth muscles surrounding the smaller airways. That's why a beta agonist or alpha adrenergic agonist will work, because it relaxes the smooth muscles. Swelling of the mucous membranes lining the airways, and that will further narrow those passages. And then sometimes we see excessive mucus plugging the airways when we have allergies or upper respiratory infections. Okay, genetic contributions. This is a polygenic disorder. There are at least 50 to 100 genomic variations that are associated with asthma development for one reason or another. If there's excessive mucus production, or there's a reactive airway because of some variation in the way the smooth muscle responds to signals. Some genes have greater influence than others, and some are specific to racial and ethnic groups. And we do see some disparities. Some of that is related to access to care and environmental triggers. But some of it is related to the genotype found in some racial and ethnic groups. Most of the genes implicated in asthma are in gene regions that code for proteins involved in the inflammatory and immune responses. You get that overreaction that causes excessive inflammation. And then we sometimes see genetically driven airway responsiveness. Like I said, the smooth muscle responds differently. It's a little more of an aggressive constriction, and increased production of inflammatory mediators like mucus. Okay, environmental contributions, exposure to inhalation irritants, anything that triggers that overreactive response. any kind of smoke, whether it's cigarette smoke or smoke from wood burning fuels, things like that. Chemicals, harsh cleaning chemicals, or any kind of inhaled irritant. Cold, dry air, more common in the wintertime, will cause that constriction of the airways. Any fine airborne particles like asbestos in older buildings. Of course, microorganisms, anything that causes an upper respiratory infection can trigger it. And if you have that pathway that responds to, it like sort of overreacts in the smooth muscle, exercise will trigger this. Aspirin and NSAIDs can trigger an asthma attack. So we would want to avoid that in people who are very susceptible. And also anything that reverses that adrenergic agonist pathway. So beta blockers should be given with caution to people with asthma. Other drugs, prostaglandins. We don't want to give prostaglandins to some of these folks. And it depends on the severity of the disease and the indication for the medication. But signs and symptoms should be very, very familiar to you. Difficulty breathing, shortness of breath, a sensation of tightness in the chest, coughing, wheezing, increased mucus production. In the later stages of an asthma attack, you will see use of accessory muscles, shortness of breath. You may see people sit straight up in tripod, but that should all be sort of review for you. From a genetic standpoint, if you have one kid with asthma, you should monitor the others and really modify your environment to reduce triggers from things like pet dander or tobacco smoke, or dust or pollen. Asthma action plan. Now, this might include control of allergies. It might include things like flu shots, but it is definitely going to include things like having a rescue inhaler for albuterol and looking at maybe longer term things, the LABAs, long-acting broncho or beta agonists, and steroids. We may need to use QVAR. Most parents who have kids with asthma are given a prescription for prednisone in case that child does catch a cold or have some other upper respiratory virus, so that they can decrease the inflammation before they get into an acute situation. Reducing the exposure to environmental triggers is super important. Steroids, bronchodilators, we already mentioned, and then support from groups like the American Lung Association, Allergy and Asthma Network. Community health agencies, particularly in communities that see disparities with this disorder, can be very helpful to these folks. And that is our content for this week. You will have a RAT, 10 questions. Good luck.